Okay, good morning, everyone. So, thank you very much for coming to this session. My name is Fatima Cardoso. I'm a medical oncologist. I'm based in Lisbon, Portugal. I'm also the president of the Advanced Breast Cancer Global Alliance, and I'm very happy to be here today together with the MBC US Alliance. And we're going to have a discussion and exchange of experiences and knowledge about communication between healthcare professionals and patient advocates. For those of you who were in the session before, the session about the Lancet Commission, you saw that what we found in one of the pieces of the work of the Lancet Commission is that healthcare professionals are convinced they are great communicators. Patients don't think so. So there's this different reality and perception of reality, and so it will be very interesting to share some experiences. So I'm going to be very, very short in my opening slides. Let's see if it works. There we go. This is what we are going to do, but I will afterwards leave my co-chair to tell you a little bit more details. I just want to show you what the Advanced Breast Cancer Global Alliance is. So we are actually a federation. Our members are organizations, not individuals. And currently we are over 270 members around the world, more than 100 countries. And the words that you see there is what represents the alliance, is collaborate and share. We don't have to start from zero all the time. And if we share what we have, those who are lagging behind can perhaps, move forward faster. And that's the goal of the alliance. Wanted also to tell you that we have a global charter. These are 10 goals that were defined together with the patients, all of the stakeholders together. And these have been our guidance for the last 10 years, from 2015 to next year, 2025. There will be 10 years. And one of these goals, which is the one that we are tackling today, is improve communication. So this workshop is one of the projects that we do frequently, promoting this exchange between patients and healthcare professionals. Just to let you know that we have started to work on the next decade, 25 to 35, and we are developing a report covering what happened in the field of metastatic disease in these 10 years and how do we move forward and what are the goals moving forward. So just reminding about the commission and ask you to, if you were not here, you didn't have the opportunity to be here, please read the report. And metastatic breast cancer has a central role in this new Lancet Commission on breast cancer. And the idea is that we need to change the mentality and the perspective of everybody, including of healthcare professionals regarding this disease. So my last slide is to remind you that we are going to have next year ABC 8, the Advanced Breast Cancer Consensus Conference, setting up the new guidelines on to manage this disease. So I'm very happy to pass the baton to Ellen. Please come. And I don't know if this will be this is your slide.
Thank you, Dr. Cardoso. As an independent member of the MBC Alliance, I'm delighted to welcome all of you to the San Antonio Breast Cancer Symposium and to this extraordinary workshop. While the Alliance is thrilled to partner with Dr. Cardoso and the ABC Global Alliance, we're also grateful that we were asked to participate in what we hope will be a meaningful and instructive discussion. So I'm here to represent the patient voice and perspective. I really can only express my own, as we all know that patients are different from one another. Let me see. Here we go. Oh, this is my whole story, which is just too long, so I'm just going to make it short. My story is somewhat unique in that I was a practicing obstetrician gynecologist when I was diagnosed with early-stage breast cancer at age 43. And then 22 years later, 6 months into my retirement, I was diagnosed with metastatic breast cancer to my spine and pelvis. I used to teach medical students, residents, about communicating bad news, about shared decision-making, and about how to properly do informed consent. Well, now I'm on the receiving end of a lot of this, and I'm happy to share with you my view of the patient perspective. We all have had different life experiences, different baseline knowledge, especially about cancer and metastatic disease. Some of us are going to take notes during our meetings. Some want to record what's going on with, the conversation with the physician. Some of us are going to bring a partner to listen and to share the experience, and some of us are going to arrive alone for the visits. Perhaps having had a prior bad experience when she brought a friend and watched the doctor talk more to her friend and her partner than to the patient herself. So despite all our differences, if I did a poll of patients and patient advocates, I bet I could find the one word we would all agree is the key to successful communication with us, and that word is listen. The best way to communicate with us and with patients is actually to listen. Listen to what we need, what we want, and what we expect. Studies have shown that even when a doctor asks an open-ended question, something like, what brings you here today? It only takes 11 to 18 seconds for that doctor to interrupt the patient. That's astounding. Not the best way to start a relationship between the patient and the physician. And the electronic health record doesn't help us at all. Some doctors just get tied to the screen. You're looking at asking yes/no questions to fill in the box. There's a drop-down answer. You're looking for specific words. It really doesn't help with expressing what people need. So I really encourage you all to pay attention to listening. I think that's the key to real shared decision-making. I also want to remind you of the harsh nature of what you're about to discuss with the patient. Sometimes we're shocked to learn that we have MBC. Sometimes we suspect that we have it, but nobody wants it. So our minds go off in a dark direction. Does this mean I'm dying? Does it mean that I won't be able to see my child graduate or attend a wedding? Or for some of us, will I even be able to have children? After being told of a cancer diagnosis, we only hear about 10% of the information that is shared. And this is where having written materials in the patient's primary language to send home with us can be really helpful. A few statements about specific language, and as English is the only language I speak, I'm going to be addressing that. First, the patient doesn't fail the drug or the clinical trial. The trials and the drugs fail the patient. Second has to do with militaristic language that we often use. We hear things about fighting and warriors. Some of us do not feel we're battling cancer all the time. We're not fighting, and when we die, we didn't lose the battle or the war. Personally, I've been living with cancer for 30 years. And while I hope to live longer, I actually feel that I've already won. I know I've been lucky, and that's why I do what I do in the advocacy world. I try to speak up for those of us who either can't do advocacy like this or are no longer with us. And the last thing I want to share is this. Don't be afraid to tell us the truth. We want the truth, and there's no need, that's the only way we can trust what you're going to tell us. And there's no need to sugarcoat things, but that doesn't mean you can't be kind and compassionate. It just means we know if you're hiding something, like a progression or if there's really no other options and it's time to discuss end-of-life issues. Personally, I think it's never too soon to talk about end-of-life issues with a patient who has MBC. How else can you help her get things in order? At my cancer center, we have a program called Death Over Dinner, during which death is treated as a kitchen table topic. And it's among family, friends, and people discuss it over a meal. And you'd be surprised at how much a patient appreciates the opportunity to discuss this, not to try to run away from the inevitable. So for the patients, I recommend just speaking up. Let the provider know what you want, what you need, and how you're feeling. They're not mind readers. And you don't have to be compliant or be the good patient. Of course, it's appreciated if you're kind and respectful, but you don't have to agree with the plan. If it's not what you want, express yourself, and you guys can have that's part of shared decision-making. If it's not convenient for you, tell the provider. It's really helpful to be prepared for your visit. Come with a list of questions, list of problems, your side effects, and your complaints, because otherwise it's hard to remember everything you want to say, and we all feel foolish when we get home and forgot to bring up the most important issue. If you have questions about end-of-life issues, bring it up. The doctor or the healthcare provider doesn't have to do this. Sometimes it's even harder for them to bring up the issues. So I especially suggest asking for palliative care consults early in treatment. It's never too early to meet with someone from the palliative care team who can help with symptoms, especially with pain, and to make sure you're comfortable. In today's session, we're going to hear advice and tips from 3 experienced physicians, and then we're already broken up into our smaller tables. We were hoping to have an advocate and a physician, a healthcare provider at every table. I think we have more people than we have facilitators, so we're going to just do the best we can when we get to those sessions and have discussions amongst yourselves at the tables. And at that point, we'll talk about challenges and share insights to improve communications. So at this point, I just want to introduce the next speaker. Do you want to do? Okay, our next speaker is going to be Dr. Reshima Jagsi, who's the chair of the Department of Radiation Oncology at Emory University School of Medicine.
Thank you. It is a pleasure to be here with you to speak about this important topic. Oh yeah, that is really long. Okay, so anyway, I'm a radiation oncologist, and I'm a bioethicist and someone who's had a lifelong interest in patient-centered communication and has been very fortunate to work with many amazing advocates that I'm seeing all around this room. So I have tried to learn as much as I can and was incredibly excited about this Lancet Breast Cancer Commission that was led by Professor Charlotte Coles, who's here and who led a session right before this, and I know some of you already heard quite a bit about the Lancet Breast Cancer Commission, but what I want to highlight for those of you who weren't in the room is that, as Fatima Cardoso highlighted just a moment ago, not only was there a focus on a theme on the group of patients with metastatic breast cancer, there was also a theme that focused on communication, and these 2 themes really went hand in hand. And communication is so essential because we know that many patients will tell us that breast cancer is a condition that feels like it's taking your power away from you. And being able to regain that sense of power and control through your sense of autonomy to be able to control your decisions is incredibly important. And it is something that's probably the most fundamental obligation of every healthcare provider in this room. And so we talked about patient empowerment, which we defined as being fully informed and supported to confidently participate in decisions about personal health and well-being to your own desired extent. And patient-centered communication has to acknowledge the unique background and need for information of each individual, consider their situation holistically, and work with patients to define and achieve shared goals in care. As we just heard, patients don't fail, but we do fail to prevent the development of metastatic disease for many. And so outcomes of metastatic cancer have actually improved considerably in the past decade. As we've learned, the median overall survival has remained about 2 to 3 years for decades, but within the past 5 years, the median overall survival has reached 5 years for 2 out of the 3 main subtypes of disease, which do account for the majority of the population diagnosed. And we have many long-term survivors who live 10 years or much longer with metastatic disease, and so some subgroups are being considered as people with a chronic disease. And so given this spectrum of disease that we have, both at a molecular level and in terms of disease burden, we need to focus on communicating in a personalized way because there's some patients who have potentially curable oligometastatic disease. Many patients will have long-term remissions or stabilizations, and then there are many patients with more rapidly progressive disease of the triple-negative subtype frequently, where their unique needs are also important to tailor our communication to address. And so management and communication must be individualized, not just on the basis of tumor biology, but also based on characteristics of the patients, including their own values. And so there are challenging conversations to be had here. There are conversations about the balance between efficacy and toxicity of treatments, between the focus on survival, quality of life, and relief of serious health-related suffering. It's delicate, it's personal, particularly in the setting of metastatic disease. As we've heard, supportive care and palliative care are crucial parts of the management of all stages of disease, but in particular metastatic breast cancer, and should be incorporated from its diagnosis. There was a survey that showed that only 17% of U.S. oncologists surveyed said that they refer patients to palliative care upon diagnosis of metastatic disease, despite 2/3 of those same respondents agreeing that earlier introduction of palliative care leads to better outcomes. We know that there's also resistance from patients and their families, often due to stigma and the perception that palliative care means only end-of-life care, which of course it does not. So what we have to accomplish as providers is a lot of things. We've got to be able to explain that metastatic disease is usually incurable, but is treatable and can be controlled for many years. We have to explain that treatment aims to slow cancer progression, reduce symptoms, improve quality of life, and prolong survival. We have to understand how the patient prioritizes longevity, comfort, and independence, and then help patients apply those values to make the treatment decisions that are best for them. It's not one size fits all, and it requires the patient to understand those goals, logistics, and side effects of treatment, and for the clinician to understand the patient's individual preferences, values, and life goals, right? Someone might want to attend a wedding, travel, meet a grandchild, avoid a change in appearance. We need to hear that, and we need to be able to elicit that information. We have to give realistic hopes and expectations. This is incredibly challenging, but also essential. Patients do want prognostic information sometimes, and they may not ask for it, but others don't want that information. And so it's up to the providers to ask if, when, and how patients want to talk about prognosis. It's best not to confront patients with information they don't want. I mean, that seems like hit you over the head obvious, but it's worth saying. And many patients do find it helpful to know the truth. There's actually no evidence that information about prognosis is harmful to patients or that it increases anxiety or distress when it's done in a patient-centered fashion. For patients who want quantitative information on life expectancy, providing ranges, like worst case, typical, best case scenarios is helpful. It conveys more hope than a single point estimate of median survival. And actually, the speaker right after me is the world expert on this, so I'm going to leave it to her to explain more about that research. There are principles and best practices for providers to build rapport, convey respect by setting the agenda and specifically asking about patient priorities, share information, check understanding, empathize, review, and make recommendations. How many of you have been in a healthcare interaction where you've walked away with only like one thing you remember? And even when you bring someone with you to take notes, and it can be highly educated people. I'm a physician. I walk away from those visits and I have missed so much. And so, as you've mentioned, sometimes recording things or it can be something that helps with that. And you need to come to a mutual understanding about next steps. Here's just some examples of language that can be used. With these are provided by experts that I know in health communications and expert clinicians that I aspire to be like. And so with these recent tests, we have some new information about the disease that I'd like to discuss with you. Unfortunately, the cancer has spread too. We can talk through what this means and what the options there are. I know this is hard to hear. I'm here to support you. We'll work with you and your other doctors to get a plan in place that works best for you and your priorities, centering the patient. Here's what we know so far about this cancer. Sometimes the hardest thing is knowing you have metastatic cancer and not yet knowing what your next steps will be. Once you have a plan and you understand how to put that plan into action with your team, I really do think it'll feel so much better. Here are the options for how we might treat this. After presenting the options, what's your understanding of what we've discussed so far? Is there anything else I should know about you that'll help me take the best possible care of you? Based on everything we've discussed, I think this would be the best option for you, but does that sound like the right path to you? Again, centering the patient, you. So there's one last complicating factor that I want to mention because there's a lot of people in this room who I think could actually help with something that really is affecting a lot of human beings in this country and abroad. In the US, we actually have the 21st Century Cures Act that prohibits information blocking from the electronic medical record. How many of you know what I'm talking about here? This is a big deal, right? So you get a little alert that says, you've got mail. You've got something in your patient portal. Now, you may get a warning that says, this may be something distressing, so you may not want to check it till tomorrow, okay? And this comes for radiology results, pathology results. Who doesn't check that email when it comes through? And I will tell you that just 2 months ago, a friend of mine, whom I saw once in a clinic visit, never needed radiation, never treated her, but a friend of mine found out through a "you've got mail" message at 10:30 p.m. at night. That's when the radiologist read the scan and released the results, and she'd been having some arm symptoms that were improving with physical therapy and actually almost didn't even go get the brain scan. Wasn't expecting anything, so opened it up at 10:30 at night and had new diagnosis of metastatic disease, first sight of metastatic disease to the brain. And the only person she could reach at 10:30 at night was her friend, the radiation oncologist. Thank goodness, right? So I called her back, and we had a 2-hour conversation about everything that one wishes to have a conversation about. She's like, should I start writing my journals to my daughter now? That was the conversation we had. The way she experienced that disclosure of her diagnosis was wrong. And I went both to that institution, which is where I was on faculty for 16 years and was the director of the Center for Bioethics, and my own institution now, and said, we've got to fix this. I can't believe this happens. And apparently, although it is by no stretch of the imagination patient-centered or ethical, apparently, most hospital lawyers are going to tell you it's legally mandatory. So this is a room full of people who can make that difference. So we need to fix this because patients should not be traumatized in this way. There's ongoing work. We heard in the prior session about the need for tools. There is much work that's being done by experts in communication and decision science, including my colleague Sarah Hawley at the University of Michigan, looking at how to develop accessible tools. And so we're actually using my Komen Senior Scholar Grant to model on a tool she created for the early stage decision making setting. And I want to call out Sarah Rohini and Jane Mizell, who are my collaborators in that work and who gave me a lot of the language for the slide that had good language. And I want to close with a quote from a patient. Above all, what matters is not to lose the joy of living in the fear of dying. I want to acknowledge the many people who contributed to the work of the Lancet Breast Cancer Commission on communication, particularly Professor Coles, who chaired it, and the junior investigator, Marika Thompson, who really did so much work on this particular theme of communication and empowerment. Thank you very much.
Thank you so much, Reshma. So we move on to the next very short. We just have 3 short, let's call them lectures or talks for highlighting the topics that we need to discuss. One was about diagnosis, and now we have Belinda Keeley from Australia that will tell us how to best communicate around progression and prognosis. Thank you, Belinda.
Thank you. It's a topic which I'm very passionate about. So I'm talking about kind of the next steps, how to talk about disease progression and prognosis in advanced breast cancer. And I think, as we've heard from the previous speakers, I think that it's really important when someone is first diagnosed with metastatic breast cancer to really help them understand what to expect. What does this mean? And I think just making it clear that for many people now, they're surviving for many years. They will nearly always be on treatment. I think that's an important thing. A lot of people sort of think maybe they'll just have a course of treatment like they did in early breast cancer, then it will stop. So I think explaining that you will, there's a good chance you will live for many years, but during that time you will nearly always be on some form of treatment. But that treatment will not work forever. And I think that's another thing to sort of try and help people understand, that they will be moving from one treatment to another. And I think some people use this analogy of the stepping stones across a river. You'll be on one treatment, it will stop working eventually, then we'll move to the next treatment. But fortunately, with metastatic breast cancer, we generally have a lot of treatment options. Most of our patients will be having scans every few months or more or less frequent, depending on how they're going. And for most people, cure is not going to be possible. So I think sort of making sure people understand that from the beginning will be helpful. Some people talk about the sort of journey of metastatic breast cancer as being like a roller coaster. So really that disease trajectory is very individualised, and it does vary depending on the subtype of breast cancer, the extent of disease, treatment response, and also individual patient factors. And I think it's helpful to prepare people for the likely ups and downs that are going to happen as they're moving through different treatments. There'll be periods where they're feeling very well and the treatment's working. There'll be periods where the cancer starts to grow. They may start to get more symptoms. We need to change treatment. So it often is this sort of roller coaster of ups and downs. And I think one thing that I sometimes find myself surprised by is this sort of unexpected deterioration. So it's a good thing now that many of our patients have very prolonged responses to treatment, and particularly first-line therapy. And so when that time comes that they have that first episode of disease progression, it can be quite a shock. And that can often be a shock for the patient, but also a shock for the doctor, because I think some of us get into this false sense of security that we've been seeing someone for a long time, they've been really well, the treatment's been working, and then suddenly it stops working. And I think it's often a very long time from those initial conversations that we had where we talked about the fact that the cancer wasn't curable. We talked about life expectancy potentially. And now it might be some years later that this first disease progression happens, and it can be quite difficult. And so I think that sort of raises this idea of, well, how should we remind people that treatment will not work forever, that the cancer cannot be cured, or should we be doing that? If someone's very well for years, should I be telling them every time I see them, don't forget the cancer's not curable, don't forget you could die from this? Like I think it's hard to get that balance of making sure people realise that this could happen, but obviously we don't want to be giving them this information every time we see them if they're well and living their lives. There's this concept of forecasting, so maybe just sort of telling people intermittently that things could change. So, for example, right now I'm hoping that the treatment will go well for you, but usually there comes a time when treatment is no longer effective, and I will let you know when that time comes. So that can be just a way of letting people know that at the time that I start to get worried, I will let you know. So moving to prognostic information. So I think this is really important for people with advanced cancer because it does help them make plans for the future. It helps with decision making. And I think communicating about prognosis is a fundamental skill for oncologists. But unfortunately, there's limited guidance to help oncologists do this well. And that's why workshops like this are really helpful. I think prognostication is daunting, so I think it is very difficult. We all find it difficult to have these conversations with patients. And I think because of that, often patients will be left with very little or no prognostic information. There are several barriers that prevent us discussing prognosis with patients. So we've surveyed Australian and New Zealand medical oncologists and asked them what are the things that make it difficult to discuss prognosis. And the sort of most common things that came up were family members requesting that the prognostic information not be discussed with a patient. That can be a difficult situation to navigate. For the doctor not knowing what the expected survival time is. So if someone says to me, how long am I going to live for? I don't know what to say because I don't know what the numbers are, so I just won't tell them. Limitations of time in the clinic, we're all really busy. We often have very short amounts of time to see people. These conversations can take time. Maybe it's easier just not to have that conversation. Fear of upsetting patients and their family members, and fear of getting the estimate wrong. What if I give them the information and I'm wrong? So I think when we're sort of thinking about when and how to discuss prognosis, like some of the other speakers have said today, I think we need to start these conversations early. So I think right from when someone is diagnosed with their metastatic cancer, rather than waiting for the patient to ask for the information, offering the information, saying something like, would you like me to talk about what the future might look like? Is there something else you would like to discuss? Some people in this situation like to know about survival time. Is that something you would like to know? So I think it's up to us to offer the information rather than waiting for people to ask, because it's not an easy thing for a patient to ask the doctor about. And I think prognostic discussions are really an ongoing process. They happen over several conversations, often over a long period of time. And one of the nice things about sort of treating people with metastatic breast cancer is you do often develop a relationship over often many years. So you do develop this rapport and this ability to have these conversations. And so over time you can discuss things like a person's values, their priorities, their preferences, their wishes. You can talk about the importance of palliative care services, end-of-life care, and also understanding how a person ranks longevity, comfort, and independence. We've conducted a systematic review looking at the optimal timing of having prognostic discussions, looking at 58 different studies, a collection of guidelines, studies of what doctors think, studies of what patients, people with advanced cancer think, and there's several sort of key time points that come up. But I'd sort of like to just focus on the two that I've marked there. At the time of an important transition, such as disease progression, I think that's an important time. And when we think a patient's life expectancy is less than 12 months, so if we think this is the sort of person we should be starting these conversations with. I think that most of our patients are having regular scans to estimate or evaluate their treatment response. And I think when we're organising scans for people, it's really important to explain the reason we're doing the scan, what the results may be, and what the plan is for good news and bad news results. So what will we do if the scan shows things are still responding? What will we do if the scan shows the cancer's growing? So having those discussions up front can be helpful. Acknowledging scan anxiety, we know this is a real phenomena. It's very common, it tends to be transient, and the peak times for scan anxiety are while people are just before their scan or waiting for the results. So I think we need to sort of organise a way we're going to deliver the results to our patients and avoid delays in that time. So try and organise a consultation to give the results as soon as possible after the scan's been conducted, ideally face-to-face. In Australia, fortunately, we don't yet have this situation where patients can receive their results in the middle of the night. I'm hoping that doesn't come to Australia, but I'm fearing it will. But I think that's a different challenge that we could certainly discuss in the next section. When the scan shows disease progression, I think it's critical for the doctor to be prepared check the result before you see the patient. So don't get the patient in the room and then start looking for the result and then you find it's progressed. And I think you need to know what that result is before the patient comes in. Be prepared for what your plan's going to be. Give the results straight away. So the patients are going to be so anxious about that scan result that as soon as they walk in the room, you really need to give them the results. I have the results of the CT scan you did yesterday, and I want to go over those results with you if that's okay. Express solidarity, so something like, I wish I had better news, if this is a cancer progression. Give the bad news clearly and succinctly and don't use too many technical terms. So unfortunately, your cancer has spread to your liver. And then I think pausing and giving the patients time to absorb what you've just said. I think a lot of us try and sort of protect the patient and minimise the bad news and change the subject. And I think you really need to stop and pause, and maybe there's going to be some silence there while this news sinks in. And then reassuring the patient that you're going to help them figure out what the best next steps are going to be. So when the scan shows progression, we know there's a tendency for oncologists to focus on discussing the next treatment. I know that we often will do this. The scan shows the cancer's growing, so then we'll just launch into this big discussion about, well, the next treatment I think we should go for is this, and these are the side effects, and this is how it's delivered. And one study has looked at this. They've looked at bad news scan result encounters and found that treatment talk actually occupied 50% of the consultation, and only 4 of 33 encounters actually had a discussion about prognosis. And I think this is really a missed opportunity, because I think when the scan shows the cancer's progressing, that's really a time when we can sort of take the chance to ask a patient about to talk about the prognostic implications of that scan and get this patient to sort of reassess the priorities, goals, desire for information. So just simply asking something like, would you like to talk about what this means before launching into the next treatment? So again, this forecasting concept. So your cancer has progressed, but we still have a treatment option. Have you considered what you want if this treatment does not work? If there is an emergency situation, have you thought about what you want to be done? So these are the kinds of questions you could ask at the time of a scan showing cancer progression. We know that patient preferences for prognostic information vary. The type and amount of information changes between individuals and also within an individual at different times. Some people just want the big picture. Is the cancer curable? Will this shorten my life? Other people want lots of details. They want numbers, percentages, best case, worst case. So we really need to find out what information do people want, what type of information, so we can give it to them. And then there are going to be people that want no information at all. And I think that asking why can be helpful, so just understanding why they don't want that information can help us understand that. But again, as our previous speaker said, I wouldn't be confronting people who don't want the information with this information. We've asked patients about their preferred format for receiving information about life expectancy. So we did a survey of patients in Australia. We gave them 2 different formats to explain survival to a hypothetical patient who had a median survival of 12 months. And we gave them this option as 3 scenarios, so explaining best case, worst case, and typical scenario, or just an explanation of the median survival. And we found overwhelmingly that our patients preferred to receive that 3 scenarios format rather than just that single number. And we've subsequently developed a website to help doctors estimate and explain those 3 scenarios. So if an oncologist puts their estimate of survival into this calculator, it will then sort of calculate the best case, worst case scenarios and create a printed format that the patient can then take home. So like we've said today, it can be helpful to have written information, because often people will go home and just focus on potentially the worst case, or they didn't sort of hear anything, didn't sink in. Having that information to take home, we find, can be helpful. We've actually done a study where we've used this website to give people their information formatted as 3 scenarios. So this is, again, just for people that want quantitative information. And we found that overwhelmingly people found this very helpful, and they also found that printed summary very helpful. We found that people did like to receive all 3 scenarios, including the worst case. So I think we're often afraid to give the people their worst case scenario, but patients do want that information. And we also found that most people, the information they were receiving was what they expected, the same or better than expected. So we weren't telling people things that were a lot worse than they thought. And I think one of the other reasons that doctors may hesitate to give information is we're afraid of telling people something that they're not expecting. But actually, most people are probably going to be thinking worse or the same of what you're going to be telling them. This is another website I've been involved in, which was really designed for patients to look at for survival times, but it's also helpful for doctors. This is sort of a website that's been developed for all different types of cancer, different stages. And you can sort of put in some general features of the type of cancer, the age of a patient, and it gives you information based on SEER data. So it's sort of collections of real-world patients followed for survival for up to sort of 10 years. And it gives sort of 10-year, 5-year, 2-year survival sort of models. So that's another good website that is more reliable for patients who are often Googling, how long will I live for? This is information that's a bit more reliable for them to receive. So just to finish off, I think that it's really important that we help patients understand the likely trajectory of metastatic breast cancer. I think conversations about prognosis, values, priorities, and end-of-life wishes are really important and need to be part of routine care. I think the absence of questions does not equate with unwillingness to know, and it's really up to us to make sure we're offering people information and offering to discuss prognosis. I think there are key time points that we should be seeing as triggers to start these conversations, in particular when we see that the cancer has progressed or when we think someone's survival is likely to be less than 12 months. And I think importantly, we need to acknowledge patients as individuals, and everybody has unique information needs about the timing and the type and the amount of prognostic information we want, and we need to find that out to make sure we're giving them the information they request. Thank you.
So I first just want to say thank you to the organizers. I feel really honored to be here with you today and to talk about this topic. And I also want to apologize that due to technical difficulties, I won't have slides, but I'll have a chance to talk with you. So what about that? Clinical trials, and the reason this is so important is because that is how we make advances. Without cancer clinical trials, we would not have all the advances and the improvements that we have seen all around cancer care and in metastatic breast cancer. But if we look at participation in cancer treatment trials, does anyone know what the number would be? A guess, a thought? Less than 10%, 7%, of which about 90% are people that are white. So that does not really represent the cancer population. So we can do better. So that's really part of the goal for the talk is how can we do better? So cancer clinical trials, how are they organized? There's a whole bunch of work that happens before a clinical trial. There's all the preclinical time. But once we have clinical trials, once we are working with humans, phase 1, phase 2, phase 3, phase 4. Phase 1, is it safe? Phase 2, is it effective? And phase 3, is it as effective as the current standard of care? And then phase 4 is post-marketing. So you know how you read about some drug getting pulled off the market because now we see that these side effects are present? That's post-marketing data. So phase 1, 2, 3, and 4, and the rationale. So important to know when a person is being offered a clinical trial, what type of trial is it? So what do we need to access a trial? First, there needs to be awareness. And that's why I love doing talks for patients, for families, because patients need to know this is an option. And activated patients can go in and say, you know what about a clinical trial? We did a study where we're just educating people. You know, you don't have to be a person with cancer to learn about cancer clinical trials. We just educate people. And then people do come back and say, I'd like to know more about that. So awareness, and awareness also for the clinical teams, and availability. Now, availability does mean, is the study open at my site? But availability also requires infrastructure. You know, it's not just the doctor, right? There needs to be a research nurse. There needs to be a data manager. There needs to be somebody who's going to be doing all the regulatory, finance people. So it's a whole infrastructure that is needed for the trial. And I would say there's also infrastructure for the patient, because the patient also needs to say, you know, maybe I want my family member to come with me. Maybe I want to learn and read about these things before I go in. So there's infrastructure for both, and there's support, the navigators, the financial counselors, the community health workers. So I wish we had a system where we did not need navigation, but unfortunately we do, and so we need those folks to be a part of it. And at least in the US, insurance coverage is critical. Co-pays, we know that one of the reasons that people do not enroll in trials is because of the co-pays. And the Association for Cancer Care Centers came up with a great program, which is the Just Ask program. Have people heard about that? Great. And it's wonderful because it's just ask, right? If you see a patient and the person appears to be eligible for a trial, just ask them. You don't need to figure out, oh, can they make all the appointments? Do they really meet all the eligibility? Just ask them. Make the invitation, and then have your team work it out. Let's work on facilitating access as opposed to presuming, they won't be able to do it. So a whole slew of factors are important to think about when we think about access. But once you have access, how do you communicate? And I think a really important question, kind of alluded to by our speakers, is what's important to you? How do you want to face this coming up period? Really important to know the person's priorities and to give time. You know, we are often rushed, right? We're often rushed. We're often thinking 10,000 miles ahead. One of the things that I'm really, not just an advocate, a practitioner of, is mindfulness, the being present. Be present. And this is really for both. Give time. And we've heard about the importance of the pause. To create an environment where questions are not just, you don't have any questions, right? Thank you, bye. But where we give space, an invitation to the questions, to the conversation, because we're listening. So creating that environment is really important. Another good question, I think, is how do you make decisions? You know, some people make decisions by, I want to learn everything about it and then decide. Some people say, you know, I need to talk with my family. Some people like videos. Some people like graphics. So can we provide those tools to the patient so that it fits their needs? And we want to think about literacy. We want to think about health literacy. We want to think about numeracy. You know, I'm sure all of you have seen consent forms. You know, they may be 20, 30 pages. You know, if a person is experiencing what's known as chemo brain, that may be really hard to get through. How do we make it easier for people? Thinking about numeracy, and of course, thinking about language access. You know, I am still so shocked that we think that somehow we can get around that. That if by not providing tools in the person's own language, by not providing speech in the person's own language, language access is critical. And we talk about plain speaking, and I think sometimes people think, plain speaking, you know, is that dumbing down? It's not dumbing down. It just makes us be clear. We want to be clear. We want to be transparent. And we want to be able to say, you know, I don't know. Let me check on that for you. Be transparent. So that in that space, the patient, the family, can really be comfortable to ask questions, to take a copy of the consent form, to write on it, to bring it back. So this may not be a single one-stop event, the consent. What should be covered in that conversation? The purpose of the study. What is the question being addressed? I've wanted to do this study, where the patient goes through the consent process and then they come out and then they're asked, what did you understand? Because often what we think we've said and what the patient has walked away with may not be the same. What is the purpose, the question, and what are we trying to learn here? How will we learn this? Who's eligible? Why? Why? We know that one of the reasons people don't enroll on trials is because the eligibility criteria do not fit the real world. So can we, bless you, have good science and still have more open eligibility criteria? So thinking about the design, how are we addressing the question? We know that the two most difficult concepts for people are randomization and double blind. So to take the time to explain those in plain speak. And what is required? The test, but not just the test, not just the studies, the time. What amount of time will this take for the patient to do this? Again, the support that's available, what can you expect? And what happens if I have a question? What happens if something goes wrong? Who do I call? Who do I contact? How can I get help? And really important, how will the results get back to you? I think that's something we don't often think about. It's like, well, they'll be published in the Lancet. We want to do better for our patients. So really today, this conversation is how can we do better than that 7%? How can we do better than almost 90% white enrollment? And we can do that by increasing availability, increasing access, and in the communication, listening, pausing, and actively inviting and working with patients and families to support cancer clinical trial enrollment. Thank you so much for your attention.
We had clinical trials, and I was fortunate. Myself, being a metastatic breast cancer patient, was with another metastatic advocate patient as well, at a whole table full of physicians. um, Go big or go home. We talked about clinical trials, and we had representatives at our table from multiple countries too, not just U.S., Sweden, Japan, Taiwan, Italy, and yeah, I forgot. But anyway, we
Sweden.
talked about clinical trials, and just like us here in the U.S., there are barriers, and they also had talked about smaller communities, as in rural communities, having access to clinical trials. That they didn't have access to clinical trials due to the fact that they weren't associated with an NCI designated hospital or their main hospital. We also talked about having the distance was an issue, and I thought maybe only that happened here in the U.S. that we have rural communities, whereas I, for example, travel 100 miles one way for my treatment by choice. Distance also was an issue, and especially in double-blinded studies. Also, the cost of opening up clinical trials at new centers was very high. They said that few centers for don't the cost of travel for patients to travel, for meals, for parking, all of that cannot be written into a clinical trial. I guess written in, I don't know, whatever. That due to pharma, not if you're in the room, yeah, pharma not covering that cost is that it, because it could be used as thinking that as an incentive to join the clinical trial. We have the clinical trials had an inability to have input on the research of protocols as well, because the smaller centers, when they get the clinical trials, everything's already done for them. So the physicians don't have um, um, any say of how it's written. Um,
Thank you. Thank you very much. Thank you. Please.
Hi, is this on? Can you hear me?
It's on.
Um, our table had communication of diagnosis, and we had a very balanced table, including two physicians, one that had been diagnosed and one that was going through a diagnostic process, and myself, who all received our diagnosis by phone. We had some people from the Young Breast Cancer Patient Coalition who actually had some statistical information from that population that over 60% received their diagnosis by telephone. We talked about finding out the information online via the portal and or maybe a phone call before or right after. And then kind of the gap there for when do you get to have the substantive conversations and have the questions answered. And it was very interesting in my experience too that highly educated people, including physicians, have a difficult time kind of navigating the next appointments, getting additional information. What's the roadmap look like? And so if that type of patient has a difficult time navigating, oh my goodness, what does that say about the general patient population at large? We also talked about the importance of physicians having, or any medical provider in the space, having conversations in anticipation of receiving your results, because due to our laws and just how busy everyone is, you may receive the results, without that supportive environment. In fact, you're most likely to. So if there can be a conversation ahead of time, you may receive this information. Here's how it may come. If it does come back showing that you have cancer, here's what we're going to do for you next. Here's when you will hear from our office next. We will see you within X amount of days. Something like that. We briefly got into shared decision-making and the importance of exchanging information between the patient and what they would like to experience from a quality of life perspective, treatment perspective, but that they need all of the information in order to make those decisions. We had someone at the table talking about a patient that had declined chemotherapy, but the nurse practitioner found out that the prior treating physician hadn't explained the chemotherapy course and options. So it was a uninformed declination of treatment.
All right, thank you. Thank you very much. We have another one. So, Beth, can you, I know, there is one over there, but while they are doing their report, you come up, please, please.
So our table over here is also covering the diagnosis question. And in specific, we were talking at the end about palliative care and end-of-life concerns and when to raise that. And we have a very well-represented table here of HCPs, physicians. We also have patients. We have industry, and we also represent across the globe. So it was a coincidence, but a very nice mix over here. So we've come upon our discussion that palliative care is extremely important, but not being used enough. And it is misunderstood. So we feel that there would be a great advantage in getting the news out so that patients can understand that this is not just for pain. It is not hospice. It also covers side effects so that patients can start using this earlier. So we would like the HCPs to collaborate with the palliative care teams and bring that to the patients early in the conversations. And this is also a good segue to move into the end-of-life conversation. And it is a multidisciplinary team where they also have other facilities available to the patients in terms of nutrition. We also talked in a separate aspect about psych-onc, so maybe, there could be segues into that as well. We also feel that the term is misunderstood, the term palliative. So maybe polling with patients to understand what is the right term to be used, because a survivorship or, fighting, these don't always resonate with patients. So what would be that intuitive term? Just as we've come upon the median is not a good number to communicate to our patients. Instead, ranges we're finding are more suitable. So we need to poll our patients to understand what's that nice intuitive term that then we could use and develop these programs and really make these programs more used by our patients.
Thank you. Thank you.
Hello. At our table, we had 3 people living with metastatic disease. We had clinicians and researchers. To just add on to some of the things that have already been said, our table spent a good amount of time talking about the use of the word incurable, usually incurable, and how that creates confusion for someone who is receiving a diagnosis or wondering what it means to be cured. And part of our discussion was it can, as we've all said, meeting the patients with where they are at. So conversations could be had about what does it mean to the patient to be cured, and also an acknowledgement that people who are living with metastatic disease and have been able to live in that 10 to 15-year range, what they learned at the beginning is different than it is now. And their acknowledgement about, are they cured, are they not cured? But maybe they're cured. Maybe it feels like they are cured. We also had a conversation about, does it mean that cured means that the progression has stopped? Does that mean it's cured, or is it stable? And that one of our patients mentioned that being told at the beginning that someday we might talk about you as being cured can give a sliver of hope. In our end of life conversation, we talked about starting early, but also acknowledging that you need to that physicians and clinicians need to provide that in a step-by-step format. Again, meeting that patient where they are. We also talked about how hard it is for a doctor to know when to talk about end of life and the guilt and responsibility that they have, that if a patient gets sicker faster than expected, there's guilt that the physician may have about not having had the time to discuss end of life because of how the patient progressed. The other theme that came out of our conversation was the patient-doctor trust and the relationship that they have, and making sure that that there's finding those spaces and tools for conversations, when the patient and doctor are meeting together. Another theme was that making sure, assessing if a patient understands the diagnosis and understands the explanation for the lines of treatment, with the general goal that the patient has confidence in the knowledge that they have about their specific diagnosis.
Thank you.
I don't think I have much to add to this. I think we've gone through the same things. We had a pretty good rounded table with oncologists, radiation oncologists, surgeons, and patient advocates, early breast cancer and metastatic breast cancer patients. I think the only thing that one of our patients mentioned was that they feel abandoned once they are referred to palliative care, and they have kind of very minimal input from their medical oncologist, which is more kind of down to resources, that we have not much input to give from the medical oncology department. That kind of leads to that scenario, but the patients feel abandoned that way, that they don't talk to the medical oncologist after the referral. So we don't have any solution for that, to be honest. But anyways.
Thank you. We're actually thinking about promoting an integrative model where palliative care is together with the oncology care, so you don't have separate departments and you don't have this feeling of abandonment. But that's a very good topic for another session. Thank you.
Thank you. Our table had an international group of patient advocates, oncologists, and researchers. And 4 things that we discussed are communication, culturally tailored awareness, comorbidities, and caregivers. For communication, we felt there was value in that clear opening line, like it's treatable. And there's importance in the relationship with the patient and the physician, as discussed, the trust and the relationship in understanding the patient's priorities and preferences. The term 5-year survival still people felt needs more explanation, that in this study, they studied patients up to this time and found, that explanation. I think there's still some gaps. Our table was very diverse and highlighted the importance of culturally tailored information and understanding preferences of diverse individuals in providing that information, statistics versus hopeful. One of our oncologists in Brazil said that her community wants to hear a hopeful message. And third, we talked about comorbidities, considering that in the discussion, and how to provide that integrated information. And fourth, caregivers, as discussed, that linkage and bridge to palliative care, when to have the discussion about advanced directives. So, thank you.
Thank you.
Hi, so we spoke about progression, and we had a few points. Actually, we stuck a lot at the first point, the first discussion point, because we were from different countries, about how the results should be presented, because in some countries patients have access to their results early before the talk actually takes place. In Germany, we don't have access to nothing because Germany. So, and then we decided in the end that maybe it could be helpful if some kind of, like in the States, there's an opt-in option, like the results are in the web, but you can decide yourself whether you want to get them. And we thought this is a good idea, that patients are being informed what is the pro and con of knowing earlier. Because, like, for example, it could be progression, doesn't mean there is a progression, but some patients may read read it like it is, and other patients might be terrified. So to educate patients about what it means. On the other hand, patients that are more like living for a long time, maybe with a disease, they know how to read it, and maybe they want to have information before in order to have a better talk with a physician and to be prepared better. So with the opt-in option, so I think we were all happy. And then the time of appointment, well, I mean, this should be also flexible, because sometimes some patients don't need so much time, especially after many years, maybe when they have a good, over the years, contact to their physicians. It can be shorter, it can be longer in patients that are newly diagnosed or have different oncologists or don't know so much about their disease. It should be flexible, but the reality is that for private patients in most of the systems, it can be up to an hour. In governmental health insurances, it's 15 minutes, and this should be adjusted to the needs of the patient and should be reimbursed by the systems, the talking oncology. Then we thought it's important to talk about next treatment lines, like maybe not only the next, but to show, even if there's another progression, so there might be another option. And there's always an option, and even symptom control is an option. And the option of not having oncology treatment should be an option in every talk. And what else did we have? Then we talked about whether family members should join the talk or not. And this is also, we thought it should be up to the patient. If she wants or he wants to have someone with them or not, I think this should be the patient's option. And even if the patient says, I don't want to be involved, talk to my mother, my husband, my brother, it's okay. But it should be the patient's decision. Did I forget something?
Thank you, Eva.
Okay,
thank you. Okay, so because of time, we will just do these two, but I will ask those of you who took notes, if it is okay to hand them over to the people in the back, please, because we would like to collect and maybe make a summary of the discussion and make it available to everyone. So for the last two, please.
Yes, we had a wonderful international table of metastatic breast cancer patients, all stages, and physicians, oncologists from around the world. And it was very interesting with regards to clinical trials. It echoes what people talked about previously, which is the main question is, how do we get clinical trials to be more accessible to patients and also to community care centers? And there was an example given by a patient that she traveled 2 hours from where she lived because she found out about a clinical trial that was 2 hours away. But the practice locally wasn't aware that a very similar clinical trial existed a few blocks away. So how do we communicate the information and let different practices know what clinical trials are happening in their local area so that patients can be referred and have it be more accessible and provide better quality of life? The other thing is just, as we all know, a lot of us, I'm living with metastatic breast cancer, are initially given that 2 to 3 year life expectancy. Yet we constantly hear that it takes at least 7 years to go from mouse to market to actually, helping the human. So the question is, what can we do to move that process along? And what are the hindrances to being able to accomplish that and have a positive effect on patients in a shorter amount of time? And if one of the hindrances that I hear a lot is, well, we can't get people to recruit for the trial, then as patient advocates, what can we be doing to help you recruit so that we can be part of the process to move it forward in a quicker way? Thank you.
Thank you.
Hi, I don't know how to adjust a microphone, so I'm just going to be brief on some major points that were from my table. That was a mix of 2 early breast cancer stage survivors and someone living with metastatic breast cancer like myself. So metastatic breast cancer, I've been living with it, diagnosed de novo for 7 years. But 2 important takeaways, being able to increase the diversity and accessibility of clinical trials. What I see what works really well is integrating clinical trial enrollment and eligibility into the patient orientation process. Whatever that patient workflow is, just making sure that however you assess that patient, that the same way that you're assessing standard of care, that you're informing that patient of the resources of the hospital, but also of the clinical trials that they could be eligible for, working with patient advocates to create that clinical trial pipeline, and also for them to engage with so that they're not so overwhelmed or intimidated by clinical trials. Another important point that we wanted to touch on when it comes to explaining metastatic breast cancer and relapse and progression and what that means is to change this methodology that we have currently internationally, that breast cancer, if you just find it early, nuke it early, burn it early, that you don't have to worry about it being metastatic. It causes a disservice. We still have too much investment in non-treatment. And so in order to make sure that patients are not overwhelmed and that they understand what the implications are with metastatic breast cancer, is to understand that metastatic breast cancer is breast cancer in general. It's not an outlier. So meaning we understand now that breast cancer behaves more so like diabetes and HIV. And so from the beginning, we should be informing patients, this is why you're on a maintenance therapy. This is what we need to do in order to create these layers to prevent the driver for the cancer to resurge in your body. And that way they're not going to be overwhelmed and culturally get away from the ringing of the bell. So.
So I'm Beth Burnett. I work with the Metastatic Breast Cancer Alliance. I'm an independent advocate and the current chair. And I just wanted to wrap up and then provide next steps. So this was an amazing session, and I thank each and every one of you for being here today. And if I bring it down to like the 4 Ps, I'm going to say partnership. It started with a partnership between the MBCA and the ABC Global Alliance. It's the partnership of advocates and healthcare providers coming together and having an interest in this topic of communication. It's the partnership of each of you having these conversations at your table and really identifying how we can work together moving forward. It's also perspective, right? I think that one of the things that I heard from this is, each of you come because you're a healthcare provider, you come with your perspective. If you're someone living with metastatic breast cancer, you come with your perspective. And being able to share what your perspectives are really enables you to hear more and what the perspective is, and then understanding and being able to take that back to your individual communities. Priorities is another thing. We identified, what fundamentally we have to find out is what is important to that individual patient. What are their priorities? What are their individual goals? And then I threw one more in because I think that palliative care needs to be incorporated into all of those things. So that's the wrap up, but I also wanted to make you aware of next steps. So we taped all the sessions. So the review sessions were recorded and will be available on both the ABC Global Alliance and the Metastatic Breast Cancer Alliance websites and online. The information, will be available on our websites. And we're hoping, if all of you think that this was a successful session, that we can continue the conversation at maybe ASCO or at SABCS next year. So hopefully everybody's on board with that. We really thought that this was a great session, and thank you for being here.
Thank you.